So we're going to talk next about urinary retention. And then in the last section, we're talking about urinary retention and urinary infection. So urinary retention is when someone is unable to void. It can be caused by a sphincter that is spasmed. It's more often caused by a bladder that's too relaxed. The management of that is catheterization. Urinary retention can be temporary, related to medications, treatments, edema, things like that, or it can be permanent because of either neurologic or structural damage. If a patient has permanent urinary retention, then they're going to have usually catheterization. We need to be aware if we're catheterizing patients of latex allergies, because a lot of catheters are latex. Even some catheters labeled non-latex actually are coated latex. And if they remain in for 3 or 4 days, the coating wears off and the latex can come in contact with the patient's tissues. We need to use strict sterile technique when we're doing a catheter in a facility. Patients who self-cath at home may use clean technique, but when they're in the hospital, we need to use sterile technique. For catheter care, a patient who has an indwelling catheter needs to be cleaned with soap and water at least 3 times daily, and anytime they defecate. We should clean from the insertion down the tubing, moving away from the patient. There are 4 acceptable reasons for an indwelling catheter. Okay, we overuse indwelling catheters. They're a guaranteed urinary tract infection. So they can be used temporarily for surgical procedures and the immediate recovery. If that's the reason for using that catheter, it needs to be removed as early in recovery as is feasible to do that. So same day or next day rather than several days later for most procedures. After a urinary procedure or trauma, a catheter may need to stay in place to allow for healing. If a patient has documented urinary retention, and even if they do, it's preferable to attempt other methods of management first. Remember that intermittent straight cath several times a day is still less likely to cause a UTI than an indwelling catheter. And if a client is incontinent and has a wound that would be wet from the urine, keeping a catheter in until the wound is healed is acceptable. Patients have indwelling catheter. If a patient has an indwelling catheter for incontinence, that is not considered an adequate reason. And they are at greater risk for infection, basically for staff convenience. So we really don't want to have catheters in for incontinence. Now, you may also, I'm going to include this under the surgical procedure and immediate recovery. Sometimes we need very close monitoring of I&Os in a patient who is acutely ill and unable to use the toilet. In that case, we would also have an Foley. Catheters sometimes get plugged and need to be irrigated. It is generally probably going to be safer to just change that catheter instead of irrigating it. But after certain surgeries, we may be irrigating the catheter. There's an open method and a closed method. An open method needs to be done with strict sterile technique. That's the drainage tube would be disconnected from the catheter tube, and sterile fluid instilled using a sterile syringe, and then allowed to flow back out in an attempt to wash out any clogs. Usually that's mucus and stuff that's gunked up in it. A closed catheter irrigation is usually done when there's been a procedure that's expected to have bleeding. Those procedures might be done on the prostate or bladder. They're expected to have bleeding. Those blood clots can clog the catheter. So closed bladder irrigation may be intermittent or continuous, and it's going to use a 3-way catheter. There's a lumen that drains the urine. There's a lumen for inflating the bulb to keep the catheter in, and then there's a lumen for instilling the fluid. And it's really important that if fluid is going into the bladder in that 3-way catheter, that you are seeing urine come out. And it needs to be, you need to monitor the amounts. because if you put 300 milliliters in and you get 300 milliliters out, there's 300 milliliters still left or there's whatever urine the patient made still left in that bladder. So make sure that you're monitoring the amount of return. I want to talk also about urinary tract infection. What are the risk factors? Women get more UTIs than men. People who have frequent sexual intercourse, and that's not because of STIs, it's because the friction actually pushes, especially for women, pushes bacteria up into the bladder. Menopause increases UTIs because the tissues atrophy and because of decreased estrogen. That actually can be treated with estrogen creams. Men who are not circumcised are more likely to get UTIs than men who are, but women are still more likely than all men to get a UTI, and people with indwelling catheters. UTI prevention, women should wipe and clean from front to back always. Uncircumcised men should retract the foreskin, wash underneath it, and replace it when they bathe. Catheters should be given regular, appropriate catheter care. We should do whatever is in our power to avoid indwelling catheters, help patients stay hydrated, and encourage them to urinate regularly. We don't want them holding their urine for long periods of time. UTI management. People will go to the store and get Azo and take that because it relieves the pain and decreases the urgency. It's available over the counter. It does not treat the infection. So we need to encourage people, just because it feels better doesn't mean the infection's gone. They need to go get antibiotics. The last section will be really short. We're going to talk about urinary diversions.